Welcome everybody. It's a great crowd, I understand tonight. So thanks for attending. I got into the headache field, just a little bit of background, back in 1991. And it was a memorable year because it was the first year that one of the triptans was launched. It was sumatriptan in 1991. So it goes back a long, long way. And back in 1991, there wasn't Migraine Canada, it was the Migraine Foundation. And we used to have Migraine Awareness Week. And before sumatriptan, the only thing we had, even when I was in residency, were the ergotamines, furanol, and Tylenol with codeine, if you can imagine. And in terms of preventatives, we had amitriptyline, propranolol, I think Sandomigraine and Sansert, which you can't even get anymore. So we've really come a long way. There was a bit of a slump in the action for about 10 years. And then Botox came back with the triptans from 1991 through to 2000. And then there was a bit of a lull again, but then now with these new monoclonal antibodies, the CGRP medications, as I'm sure you've all heard about, there's been a real flurry of activity. So there's a lot happening in the migraine world. Having said that, unfortunately, the data that I'm going to be presenting to you in migraine in the female life cycle, a lot of it's old data, and some of it goes back to 1970 with the original research being done by somebody called Somerville, where he basically made the discovery that migraine associated with menses was because of a drop in estrogen levels. And it's sad to say that we haven't really come that much further in terms of some of the studies. We do have a few studies that looked at treatment of menstrual migraine, but it's very interesting that that hasn't really propelled forward that much. So with all that, what we're going to do this evening is go through the life cycle of migraine. You'll see that migraine is with the female patient right from the time they start puberty, right through menstrual cycles, through pregnancy associated with hormones and hormone replacement therapy, pregnancy, breastfeeding, right into menopause, and sometimes after menopause. So we'll walk through this cycle tonight together. And if you have questions, you can put them on the chat and we'll save them till the end and deal with them then. You'll see that I've introduced, these are my disclosures, by the way, but they really don't have a lot of relevance here. And what we'll do this evening is we'll talk about the effects of hormones on migraine throughout the life cycle. We'll talk about some of the treatment strategies of menstrual migraine in particular, and discuss the effects of the oral contraceptive on migraine and aura in particular, and the effect of stroke risk, and then touch a little bit on pregnancy, on migraine and breastfeeding, and also review some of the treatment options that we have available. So just a little bit of background in terms of what migraine is as far as the international headache criteria are concerned. There is a large series of headache diagnostic classifications, over 200 of them that are classified in the international headache criteria. So migraine without aura, which is by far the most common that we have. These are the criteria that are suggested to make the diagnosis, and we need to have at least 5 attacks. The attacks last anywhere from 4 to 72 hours, and they have to have more than 2 of the following. So they have to be one-sided, pulsatile in quality, moderate or severe pain aggravated by activity. During the headache, we like to see more than 1 of the following, including nausea or vomiting, sensitivity to light, which is photophobia, and sound phonophobia. Now, we also need to rule out the fact that this might be related to an underlying disorder, either a tumor or infection or something else that makes it clear that it's not migraine related. I'm going to suggest to you that these are suggested criteria. We clearly see patients who have migraine that don't meet all of these criteria, but based on the clinical history, they certainly do fit the pattern of migraine. And then we have migraine with aura, which is far less common, and you may have both within the same patient. You may have a patient who has migraine without aura their whole life, and then lo and behold, when they become perimenopausal or when they become pregnant, they start to develop auras. And auras really are a set of symptoms that are neurological, and they could be anything from visual to sensory, meaning numbness and tingling, or they could be motor, meaning paralysis. They could involve speech or language. But typically they occur before the headache comes on. They could last 5 minutes, 20 minutes, or even an hour or more. And then the headache follows this. And again, that's the typical pattern. There are some that evolve much, much slower. There are some that are actually occur during the headache themselves. But less than 15% of patients who have migraine with aura. So much less common. Okay, so let's get to the prevalence in women. As you see the bars here, the orange bars represent females, the green bars represent males. Across you see the representative ages of patients. And as females start puberty around the age of 14 to 15, we start to take off in terms of the prevalence of migraine for that year. They really peak between the ages of 25 down to about 45 to 50. And as women go through menopause, the migraine prevalence reduces. So for every one male, you have 2 or 3 females that have migraine. If we were to look at this bar starting at the age of 5 going up until menarche, which is when we start our menses, that bar would shift because the prevalence is higher in little boys than it is in little girls pre-puberty. So they tend to have a higher prevalence before we start our menses, and then after menses, they take off in the female population. Ovarian hormones have a lot to do with this. 80% of female migraineurs have their first migraine between the ages of 10 and 39 years. I suggested that there were studies in the 70s done by somebody called Somerville, and he identified there was a drop in estrogen just before the menses occurs, and that seemed to be the culprit for triggering migraine. We know that estrogen increases serotonin synthesis, and you've heard about serotonin in relation to the triptans, things like Imitrex and Zomig and Maxalt, those medications that you take when you get a migraine affect serotonin. We also know that estrogen decreases serotonin degradation, and estrogen also affects things called prostaglandins, which are things that cause inflammatory changes when a migraine occurs. Magnesium, which we know has a protective effect on migraine, and nitrous oxide, which I'm going to suggest to you stay tuned, because right now research is happening with regards to nitrous oxide and its protective effect on migraine in terms of nitrous oxide related medications. So it's going to be coming up in the near future. So I presented some cases here because I think that it may be an easier way to relate to some of the changes related to migraine, and you may be able to relate to some of the details in the cases. So we'll walk through a couple of cases together. So this is a 32-year-old woman. Her migraines began at the age of 12. Her menstrual cycles began at around the same time, within about 6 months of her migraines beginning. Initially, they were about 3 times a month, but the headaches that occurred during her menstrual cycle were typically much more severe. They lasted longer, and she would get occasional visual symptoms associated with her migraines. So she would describe seeing a kaleidoscope in her vision. Sometimes she would look, and it would feel like sometimes in a hot summer day when you see the heat waves rising off the pavement. She would sometimes see some flashes of light occurring with these headaches that occurred with her menstrual cycle. The only relevance to her history was that her mother had a background history of migraines, but she was otherwise well, no real medical problems. So what's the diagnosis? What are the things that go through our mind when we see a patient who presents with this? We think about migraine without aura. We think about menstrual related migraine, and then true menstrual migraine. Those are all the diagnostic considerations that we have. So what's menstrual related migraine? That's by far the most common. And that's typical headache that occurs anywhere from day -2 to day +3. And by that, I mean, if you look at your menstrual cycle, day 0 is the day that you start menstruation. Day -2 is 2 days before that. And day +3 is 3 days after you've started your menses. So the timing of treatment really relates to when your headache begins, not when your menses begins. And that'll become clear to you in a moment when I start to talk about treatment. Premenstrual syndrome, headache onset day -7 to day 0, were the headaches associated with PMS, so different than menstrual related migraine. And the headache usually resolves as soon as they start their menses. So that's how we distinguish the two. Again, menstrual related migraine, there's about a 5-day period that's around the menstrual cycle, but it continues into the menstrual cycle even after menses starts. But PMS related headache tends to stop with the onset of menses, and as you are well aware, has a whole series of other symptoms associated with PMS. Menstrual migraine is a bit unique in terms of other migraines that you may get during other times of the month. It's perceived by both physicians and by patients as being much more severe, longer duration, refractory to treatment. It doesn't usually respond as well to the usual medications. So you could take an Imitrex or a Maxalt or naproxen or Aleve for your other migraines during the month. But when you have a menstrual migraine, it just doesn't seem to work. It doesn't last as long. It may take the edge off the headache, but it doesn't eliminate it completely. There are no studies to back this up. This is just purely anecdotal experience. So if you look at migraine attacks in relation to the menstrual cycle, I spoke to you about menstrual-related migraine, and menstrual-related migraine takes up about 50% of migraine attacks related to the menstrual cycle, so by far the most common one. Then you have migraine attacks that aren't really associated with menses that represent 40%. There's a small percentage of patients who have pure menstrual migraine. So these are women who don't have migraines at any other time of the month. They're not triggered by alcohol or weather or anything else. They strictly have pure menstrual migraine. Very uncommon. We don't know if physiologically they are any different. They do respond the same as menstrual-related migraine, but they're still very difficult to treat and still don't respond as well to medication as menstrual-related migraine. So the question has always been, are they a different type of menstrual migraine? Are they physiologically different? We really don't know. And as I said, there's a real lack of studies that are being done over the last 10 or 20 years in this area. So we really don't know very much about it. So menstrual-related migraine occurs in about 60% of women who have migraine, so it's quite common. It tends to occur day -2 to day +3. It can vary, plus or minus 1 or 2 days. Estrogen withdrawal headache, it can occur when patients are taking exogenous estrogen, hormone replacement therapy, oral contraceptives. If they're taking those every day and then they stop it, just like the birth control pill, and you can get that estrogen withdrawal headache. So you're on oral contraceptives, you stop it for your days off, that's when your headache may occur. Menstrual-related migraines tend to produce more disability than regular migraines do. They tend to be more severe and, as I mentioned, less responsive to treatment than non-menstrual migraine. And they lead to higher medication overuse and more chronification of headache and higher disability rates. So how do we manage this particular patient? She needs acute therapy. So we would try the usual therapies. We would try anti-inflammatories. We would try triptans, the usual things that we would try to treat a regular migraine. And as I mentioned, they don't typically respond as well. And so the one thing that helps us a little bit is if a patient, the one question that we ask when a patient presents like this, two questions really. Do you have a regular menstrual cycle? So in other words, is your cycle predictable? Does it happen every 26, 27, 28 days? That's one thing that can help us. And the other thing is the onset of your headache predictable? So if a patient comes in and says, my cycle is every 27 days, I can tell you my headache starts day 26, the day before, and that's predictable 100%, then that helps me because what I can do is I can pre-treat her on day 25. And sometimes it's called a mini preventative treatment. And we do that for about 5 days. And I'll talk a little bit more about that. So that's one of the things and one of the approaches. And that's what's meant by short-term menstrual migraine prevention. Other things that we can do, magnesium sometimes can be helpful for menstrual migraine. So we tend to put patients on magnesium, 300 milligrams twice a day. Non-steroidal anti-inflammatories, that's what NSAIDs is. So things like naproxen or Aleve or ibuprofen or Motrin. Triptans are helpful for this, ergotamine, and hormones. So things like the estrogen patch. So those are all different classes of drugs that can be used for this. Okay, I think we'll deal with the questions at the end, if that's okay. So before we start talking about what drugs we use in a little more detail, the one thing that I really want to stress, and this is important for any patient when you're treating migraine, when I see patients in the office You know, we spend a fair bit of time talking about education, talking about lifestyle, because before we even get to medication, lifestyle is really one of the most important things. And when we talk about lifestyle, we start with things like sleep hygiene. And by that, we mean regularity in sleep, trying to go to bed at the same time, waking up at the same time. We know that irregularity in sleep can trigger migraines in patients. If you sleep in on the weekend, you're more likely to get a migraine. If you go to bed too late, if you're sleep deprived, these are all triggers. So doing the best you can to maintain regularity in sleep. Migraine brains hate changes. They don't deal well with changes, whether it's sleep or exercise or diet. We really don't do well with changes in our routine. Keeping a diet diary, maintaining regularity in your diet, making sure you have 3 meals a day, not going prolonged periods of time without eating, and having a good protein intake first thing in the morning. Exercise, we recommend 3 times a week for minimum 30 minutes at a time. Being aware of medication overuse headache, that's MOH, medication overuse headache, so taking analgesics or triptans more than 3 days a week leads to medication overuse headache, which is a chronic daily background headache. Caffeine, minimizing that to no more than 1 or 2 cups of coffee or tea a day, and being careful where your source of caffeine comes from. If you're drinking Starbucks or Tim Hortons, be aware that that's probably the equivalent in terms of actual caffeine of 3 or 4 times the amount of caffeine that a home brewed coffee would be. We try and deal with smoking and alcohol related excess, because that can certainly trigger migraines as well. And all of my patients get started on magnesium, B2, and vitamin D. I save CoQ10 if they fail the first 3 vitamins. It's a bit pricey, but it still can help as a preventative. And the trend now is not to put patients on butterbur as much. The dosages of vitamin D are 2,000 units and CoQ10 is 75 milligrams 3 times a day. These have all been shown in studies to have benefit in prevention for migraines. So these are all useful things to do for add-on therapy before we get to the actual medications. So this is a list of all the acute treatments for migraine, and this goes across the board, not just for menstrual migraine. And this is based on the Canadian guidelines. These guidelines were published in 2013, and a group of headache neurologists in the Canadian Headache Society, we basically reviewed, and I'm sure there will be webinars on acute migraine treatment, but the studies that were done on acute migraine therapy were all reviewed, and then the recommendations that you see on the right-hand side of the screen were made on the basis of the quality of the study and what we felt was good practice. And so those are all the classes of medications. You see that there is Cambia, which I'll talk about, diclofenac, which is an anti-inflammatory, aspirin, ibuprofen, naproxen, also anti-inflammatories. And then they get into the triptans and the older drugs, the ergotamines and the opioids, which have a weak recommendation for use. So those are guidelines that have been made to family doctors and prescribing physicians for headache management that are used. Few words about the triptans. Sumatriptan is the first one that came out in 1991, followed by all the others. These are all available in oral tablets, but as you can see, there are some that are available in a melt form or a wafer. A couple are available in a nasal spray, and one sumatriptan is available in an injection. They all work the same. They are all acute therapies, but the difference with a couple of them is that they have a longer half-life, which means when you take them, they last much longer. So they're actually very good choices for menstrual migraine, because menstrual migraines tend to last longer than a regular migraine. So you may have them for 2 or 3 days. So the ones like Emerge or Naratriptan and Frovatriptan tend to last more than 12 hours. So the advantage to that is you don't need to take it 2 or 3 times in a day for it to be effective for your menstrual migraine. So we tend to choose those for a treatment for us when we're treating patients who have menstrual migraine. So Cambia, for those of you that may be my patients or have seen a headache neurologist, may have Cambia. Cambia is an old drug with a new formulation. It's a drug called Arthritech, diclofenac potassium. So it's been around for a long, long time, but what makes it unique is that they've now they formulated it into a powder. So by doing that, it works much faster. You'll get plasma levels as early as 15 minutes. And you just put it into 2 ounces of water. It tastes minty or aspartame, or not aspartame, anise-like. And you drink it down quickly, and it starts to work within about 15 to 30 minutes. It doesn't last, it lasts about 3 or 4 hours. And some neurologists who deal with migraine and headache a lot, we tend to combine this with one of the slower acting triptans that lasts longer, because this starts things off and then the triptan will continue for a good 12 hours. So something that's the new kid on the block, I don't know if any of you have had this prescribed, is called Suvexx. You've heard me talk about Imitrex, you've heard me talk about naproxen or Aleve. And what this medication is a combination of sumatriptan or Imitrex and naproxen. And what makes it unique is that it works faster than each of these two drugs individually, and it lasts longer. And this was approved in the US in 2008 and was just approved in Canada in 2020, in February of last year. And they've actually done menstrual migraine studies with this drug, and it has shown tremendous benefit. In the menstrual migraine study that was done in 2009, if you'll see the two graphs here, there's one that is 2-hour pain-free. If you look at, these are two studies, study 1, study 2, the green bar is for the Suvexx, the blue bar is placebo. And in study 1 and in study 2, these were given to patients who had menstrual migraine. The patients who were in study 1 and study 2 with menstrual migraine had pain freedom at 2 hours in about 45 to 47% of the time, as compared to placebo, which was 23 and 22%. The other thing that was significant is if you look at the next graph that looks at 24-hour sustained pain-free. What does that mean? That means they had pain freedom at 2 hours, but they maintained that pain freedom for 24 hours. Pretty impressive. And so the numbers, if you compare the blue bar to the green bar, still pretty impressive. So up to 30%, and in some cases in the second study, over 40% compared to 10% of placebo. So Suvexx is actually a very good choice for menstrual migraine. And the other thing that they showed in this study was that not only did it treat the menstrual migraine, but it treated the menstrual related symptoms. So the cramping, the back pain, the irritability, and the dysphoria that you feel with menstrual migraine or PMS related symptoms. So really good choice. So remember that one and talk to your family doctor about it. And it's a combination of naproxen and Imitrex. So again, you have to be careful that you can take naproxen or anti-inflammatories. And because sumatriptan has cross-reactivity with Septra, you have to make sure that you don't have allergic reactions to that particular antibiotics. Okay, so I talked to you about some short-term studies that were looking at migraine with mini prevention. And that short-term study, one of them was done with anti-inflammatories, which is naproxen. Naproxen's only one of them. And essentially what they did was they looked at patients who had a regular menstrual migraine, a predictable onset of headache, and they gave them naproxen sodium twice a day for 5 to 6 days. And they were able to prevent the menstrual migraine from happening. They also did it with these particular triptans. So that's Imitrex, naratriptan is Emerge, zolmitriptan is Zomig, and frovatriptan is Frova. And what they did with these patients is they started these medications 2 days before the migraine was to begin, and they were taking them twice a day for anywhere from 5 to 7 days, and they all showed some benefit in preventing that menstrual migraine from occurring. They also did a study using the estroderm patch, and the estroderm patch was applied 48 hours prior to the menstrual migraine starting, and the patch was changed at day 3. Another patch was applied, and this also showed some benefit. When they did this with the oral contraceptive, it was less effective. So the patch seemed to work. Not great numbers, but certainly some benefit. What I've had some luck with is combining the estroderm patch and the naproxen, where I give them two. I do naproxen preventatively, and I give them the estroderm patch preventatively. So the combination of the two seems to work quite well. So now getting back to our patient, now she's 35. Headaches have been controlled using topiramate or Topamax for a preventative. She's also been on Botox. She's now down to having 3 headaches a month, and she treats them with Maxalter rizatriptan, but now she wants to get pregnant. So what do we know about migraines in pregnancy? Well, the good news is that up to about 70% of women get better during pregnancy. So that's the good news. The bad news is that the 30% of women who don't get better during pregnancy get worse. Some of them get worse during the first trimester alone, and then they tend to improve. But there's a small percentage of them that get worse and continue throughout the entire pregnancy, as well as throughout breastfeeding if they're going to breastfeed. And they can be very challenging because these headaches can be very, very severe. Something else can also happen where they may experience a new onset of aura. So they may have never had aura before, and they start to have these auras, whether they're visual or whether they start to have numbness or tingling. And these are frightening because there are many other conditions, and you can't just assume that it's migraine. So we tend to start investigating these women to make sure that it's not something else. If they do well during pregnancy and their headaches go away, chances are quite good that they're going to continue to stay away once they're breastfeeding until they stop breastfeeding, and then they're likely to come back. So how do we treat these patients? It's really quite challenging because there's not a lot of things that we can give them. We tend to approach a do no harm approach in the first trimester in most cases. We try not giving them anything if we can. Tylenol is quite safe during pregnancy and breastfeeding, so that tends to be our go-to analgesic. Very often there's nausea, so we use things like metoclopramide or Maxaran, and it can be given orally or intravenously. Promethazine can also be used, or ondansetron, and these are the antiemetics that they tend to use in cancer patients or chemo patients. We avoid opioids during pregnancy, and we used to use magnesium sulfate, but now because of some potential skeletal abnormalities and bone loss in the fetus, we avoid that. It can be used in high doses in the emergency room once or twice, but we're not giving it preventatively like we used to. Triptans were never considered safe up until 3 years ago. And when sumatriptan first came out, and now with all the triptans that have followed, there's something called a pregnancy registry. And basically what that means is when a patient has been taking a triptan, if they become pregnant while they're taking it, they're entered into the pregnancy registry for that particular triptan. And so sumatriptan, which is the one that's been around the longest, has over 5,000 patients in the pregnancy registry. And so there really haven't been any published increased rates of defects or spontaneous abortion or other adverse pregnancy outcomes in comparison to the normal population. So with that many patients in 2017, they basically said, you're okay to use sumatriptan during your pregnancy if you need to. But again, we try and avoid it if we possibly can in the first trimester, and I wouldn't recommend using it. There's no data yet on drugs like elatriptan or Relpax or Frovatriptan because we don't have a high enough number in the pregnancy registry as yet. In terms of prevention, there are some medications that we tend to use. I mean, cyproheptadine is rarely used, but it is a preventative. It doesn't have great data to support its use. Fluoxetine or Prozac and sertraline can be used, but again, not a lot of studies to support their benefit. We tend to use beta blockers, so propranolol, Pindolol, or labetalol. And also amitriptyline can be used during pregnancy, or Elavil. But again, these are used in the second trimester and third trimester. We avoid them otherwise. So now she's 16 weeks pregnant. Her headaches are persisting. They're happening 2 or 3 times a week. She's vomiting. She's not able to work, and she can't take acute medications because of the vomiting. So at this point in time, we would start her on a preventative. And the preventative, we would probably go with amitriptyline because she's not sleeping well. She's developed some anxiety. We could use propranolol as well, but we have to stop some of these preventative medications prior to delivery because they may affect the fetus. And we could use aspirin, but we again tend to stop it prior to delivery. I tend to avoid aspirin completely during pregnancy, and I'll stick with Tylenol. And we even use Tylenol with codeine in some circumstances. Again, we tend to use non-medication approaches as much as we can. So I refer them on for massage therapy. I use essential oils. There's something called cephaly. You may or may not be familiar with it. It's like a stimulator, a neural stimulator. It's something that you can put on. If you've seen it advertised, they sell them at Costco. It almost looks like a Star Wars headband that you wear on your head, and it gives impulses. But it's not going to do any harm. The data is not overwhelming, but it's something that may give them some added benefit, and it's not going to harm them in any way. So you really pull out all the stops for things that are non-pharmacological during pregnancy. We also look at supplements, but again, checking with the OBG, because some of them really don't want supplements during pregnancy. And then sometimes nerve blocks will be helpful. I've referred patients for nerve blocks. We treat the occipital nerves at the back or the supraorbital nerves just above the brow. Acupuncture may be useful. And magnesium sulfate we tend not to use anymore. Again, we focus on lifestyle, hydration, exercise, sleep hygiene, and caffeine, all the things that I mentioned to you before, but we really tend to emphasize that a great deal during pregnancy because we can't really use medications as much as we would like to. Botox is something that is always questioned during pregnancy. And although there are no reports of anything occurring untoward using Botox in pregnancy, we tend to avoid it. I have probably 3 patients that I've given Botox to during breastfeeding. Again, there haven't been any reported issues associated with it, but no one in the company or there is no one that will tell you that you can use it. There really haven't been any published papers to say that it really causes any harm or that it's contraindicated. It's really a question of risk versus benefit. And the patients that I've used it in were patients that had it prior to pregnancy and had severe emesis and throwing up and severe migraine that they really couldn't even bond with their baby after delivery. So I used it in the postpartum period while they were breastfeeding. So these are just, I don't expect you to read this whole slide. These are just some of the conditions that we get concerned about when a patient presents with migraine-like headaches in the postpartum period, or even prepartum, eclampsia, idiopathic intracranial hypertension. We always worry about a bleed in the brain. We worry about a tumor, a pituitary bleed. We worry about something called cerebral venous thrombosis, where you get clotting in the venous system, and then just some very, very rare conditions. But the point is that even though they may have a history of migraine, if things change and if they develop an aura, or if there's a significant worsening of headache and they haven't been investigated, it may be time to do something. We tend to investigate by doing MRI scans during pregnancy rather than CT scans because of the radiation. MRI scans are safe. There are some centers that won't do them during the first trimester, so we tend to wait if we can. If it's an urgent situation, there isn't a problem. There haven't really been any reported problems doing MRI during pregnancy. So postpartum, the things that I've just mentioned are issues, particularly if they've had epidurals. We think about a spinal fluid leak, and we always have to have a heightened level of awareness to make sure that we're not just calling this a migraine. We have to think about other things and have a high index of suspicion for other conditions that it could be mimicking. And also in lactation, the same rules apply for the medications that we use. So Tylenol as an analgesic, a triptan if we need to. If you're using a triptan, we tend to use sumatriptan injection, and it's the pump and dump where you give yourself the injection and then you pump your breast milk, dump it for 4 hours, and then you're good to go breastfeeding again. I think I've mentioned that already. These are the Hale categories, and basically this is how they categorize the medications in terms of safest, safer, moderately, and contraindicated. There used to be mother risk, there no longer is, so now we refer patients to ToxNet as a reference for what's safe. I always recommend my patients contact them or read about it before they take any of the medications that are prescribed for them. Okay. So this patient is now 26. This is a different patient, and she was diagnosed with migraine with aura in her teen years. So the aura, as you recall, could be the visual symptoms, the numbness and tingling. This one in particular had visual auras. They were called scintillations, so zigzag patterns, a lacy doily pattern, and fortification spectra, which is basically almost like if you look at a starry or a zigzag pattern that's half of a lacy doily almost on the outside of her peripheral vision. And her aura would come on lasting about 5 or 10 minutes. And after that, the migraine would follow. She has about 5 migraines a month. She has 1 severe attack during her menstrual cycle, and she uses anti-inflammatories about 5 times a month to manage them. She wants to start the birth control pill. What do we tell her? What are our concerns in using the birth control pill in migraine? So do we tell her to go ahead? Do we tell her she cannot take it at all with any kind of aura? Do we tell her to start the progesterone only pill if she has aura, or she can start the low dose? She can start low dose. That should be estrogen, sorry, not best. Low dose estrogen or progesterone only in migraine with aura and visual aura. And if the aura worsens or the headache increases, stop it. So essentially the answer is C and D, and we'll talk about why. So she can start progesterone only in migraine with aura if she has a visual aura, or she can start the lowest dose estrogen or progesterone only in migraine with aura if it's a visual aura. If it worsens or changes, she should stop it. And the reason is that we worry about stroke, and we worry about stroke risk in migraine with aura. So if you have migraine without aura, your stroke risk is no higher than the general population in a woman your age. Where things start to change is when you have migraine with aura. And we don't think that if you have visual aura with your migraine, it's that much different than the migraine that doesn't have aura. So if they're uncomplicated visual, we don't get too concerned. However, your aura does increase your stroke risk very slightly. If you have migraine with aura, it does increase stroke risk. If it's once a month, you have a 2-fold increase. If it's once a week, it's a 4-fold increase in stroke. Both oral contraceptives and migraine with aura independently increase the risk of stroke. So if you're on the birth control pill, your stroke risk is increased. If you have a history of migraine with aura, your stroke risk is increased. You put them together, your stroke risk is higher, even so. It's the stroke risk is higher. It's greatest when you have a high dose of estrogen, so greater than 50 micrograms of estradiol. It may be a minimal increase in the risk if you have oral contraceptives with less than 20 or 25 micrograms of estrogen, even if you have a simple aura. So in other words, the message is if you have migraine with visual aura, you want to go on the oral contraceptive. The lowest possible dose of estrogen would be the way to go without significantly increasing your risk. The other possibility is to consider progesterone only, because progesterone will not increase the risk of stroke. In fact, it may actually reduce migraine frequency and severity, and it may be safer than continuous oral contraceptives in migraine with aura. So this is a chart that's very busy, and if you look across the top, ACOG is the American College of Obstetrics and Gynecology, WHO. You've all heard about that by now with COVID, the World Health Organization. And IHS is the International Headache Society. So if you have headache that's non-migrainous, this is in regards to could you start a patient on the pill? And if you have a headache that's non-migrainous, everybody's happy. Go ahead and start it. If you have migraine without aura, the OBG people and the WHO said, yep, no problem. So migraine without aura, if you're under 35, everybody's still happy, except for the international headache people. They say do a risk assessment. Just be careful. If you're over 35, everybody seems to agree, risk assessment. And the gynae people in WHO say the risk outweighs the benefit. So they hesitate on that one. If you're a smoker, both the gynae people and the WHO, so the risk outweighs the benefit. The International Headache Society basically says stop smoking before you start the oral contraceptive. Where we get into a bit of an issue and a bit of a disagreement is when you have patients who have migraine with aura. You'll see definite crosses both with the gynae and the World Health Organization that migraine with aura, no birth control pill, period. That's it. However, when you have the International Headache Society says essentially do a risk assessment. If you're a smoker, stop smoking. If you have migraine with simple visual aura, you can start a low dose estrogen, oral contraceptive. If something happens where your auras increase or change, you stop it. And if you have additional risk factors on the bottom for stroke, hypertension, obesity, diabetes, you do a risk assessment and you determine based on each patient if the risk is higher than the actual benefit. So they're slightly different. The international headache people are a little less conservative. The WHO and the gynecology people in the US are definitely more conservative. The bottom line is you need to do risk and benefit assessment for each individual patient. You need to caution the patient, and patients need to know if they're started on oral contraceptive or hormone replacement therapy. They need to watch themselves for a change in the frequency of the headache, an escalation in the severity, or a change in the pattern of the headache. If they've had simple visual auras and all of a sudden now they're developing numbness or tingling or paralysis or difficulty with their speech, then they need to contact their physician. If their auras start just when you started the birth control pill and they've never had auras before, they need to tell somebody about it. Or if they have any new associated symptoms, if things have changed, they need to contact their physician. We always recommend, if you're starting hormone replacement therapy, a headache diary, and always use the lowest possible estrogen dose in the continuous birth control pill that you can. Monitor the use of triptans and monitor the frequency of the use of triptans when you're combining the two. The studies are poor. We don't, as I said, they haven't been done for quite a number of years. We don't have, we have different methods. You'll read one study that will tell you this is the stroke risk. You'll read another study that will contraindicate or contradict that particular study and say, no, this is the actual stroke risk. You've seen that we can't even get agreement between large bodies such as the WHO, the OBG School of Thought, and the International Headache Society. But essentially, I think that if the message you take away from this is if you have migraine without aura, and someone wants to go on the oral contraceptive, again, the lowest dose of estrogen possible. If you go on the oral contraceptive or hormone replacement and you get a change in pattern of your headache or a new onset of aura, it's time to reconsider and look at something else or look at an alternative at that point. And if you have migraine with aura that's anything but visual, you should avoid estrogen-containing oral contraceptives and consider progesterone only. So now Jen's 48. Her migraines have increased. They're less predictable. She's had a change in the character of the headaches. They're lasting longer. They're not occurring every 28 days. The triggers aren't really predictable. They're less responsive to treatment. They happen every 10 to 15 per month. So they're much more frequent. She's sleeping poorly. She's gaining weight. She finds that her mood is actually affecting her as well. So something's changing, and she's 48. How do we manage her? Well, do we consider imaging her? The answer is yes, because it's a change in her pattern and she's 48 years old. Do we try a non-pharmacological approach? Always. That's part of your armamentarium, even before you start medications. So we look at the vitamins, we get her to keep a diary, we look at her lifestyle, has anything changed? So we reevaluate that all the time when they come in and there's been a change. Maximize her acute therapy. If she's been taking triptans, maybe we want to try something different, because you all know that if you've been on a triptan or something for 6 months, sometimes you need to change. Consider prophylaxis or a change in her prophylactic, all of the above. So yes, we do all of these things to manage her, and we do investigations as well. Something happens when we approach menopause. Something happens to our hormones. We get fluctuations, and before we get a drop in estrogen, we get fluctuations. It goes up, it goes down, and it's a wavy pattern before it eventually starts to peter down. So every time you get a rise and a fall and a rise and a fall, And anybody who's headache prone with menstrual migraines, for example, that's when they're going to get the storm before things eventually peter out. So typically that's what happens. And if you've got a woman who starts to get worsening headache and she still has her period, you can almost bet that within 6 months, she's going to start to get irregularity in her menstrual cycles and she's heading towards menopause. And it usually is associated with the fluctuations in her estrogen levels. But the good news is it's probably going to get better after the menses settles down in about 70% of women. So she's going to ask you specific questions. Are her headaches going to get better after menopause? Can she use the same triptans to treat them? Does hormone replacement therapy help? Which one should she take? And the question on top of everybody's mind is, well, why not just do a hysterectomy? The answers are, will the headaches get better after menopause? In most cases, yes, but you may need prevention to get you through this unstable period in the meantime. Can you use the triptans? Probably yes. And the only reason I say absolutely is because she's 48. Make sure she hasn't developed heart disease. Make sure she's not smoking. Make sure she doesn't have any other cardiovascular risk factors like hypertension. Does hormone replacement therapy help? Yeah, it might. And you might consider low dose hormone replacement therapy in this situation to even out those hormonal fluctuations. And what about a hysterectomy? The answer is no. There's no evidence that a hysterectomy makes any difference. And in fact, it may make the situation worse. Surgical menopause is not the answer for this situation at all. So if you're tempted, don't do it. We don't typically use hormone replacement therapy as a first line. We would only use it short term, and we tend to use prophylaxis that we use for migraine. If that hasn't worked, then in conjunction with the gynecologist, we may consider hormone replacement therapy. But typically, if they're having other things like hot flashes, dryness of the skin, memory-related issues, that's when we'll go to hormone replacement therapy. It's not common to use that strictly for the headaches and the migraines themselves, because the hormone replacement therapy can actually make the headaches worse. And if you find that the headaches are worse with the hormone replacement therapy, we try reducing the doses. We use non-cycling so that we give them to them continuously. We may change from a conjugated estrogen to pure estrogen, switch it to a patch. We might manipulate it in a few ways to try and minimize the headache, but there are some women that really cannot tolerate HRT at all. So as I said, 70% of women will get better. And the worsening around the perimenopause is not at all unusual, and we could use HRT. So where does that leave us? Just a few little pearls to take away. Migraine with aura increases the stroke risk 2 to 4 times in women. The baseline absolute risk is still very low. So, I mean, when we say the stroke risk is increased, I don't want you walking away thinking, oh my God, I have migraine with aura, I see flashing lights, so I'm going to have a stroke. It's very low. It's still anywhere between 5 and 10 women in 100,000 per year. So really low numbers. Estrogen oral contraceptives are not absolutely contraindicated in migraine without aura, and the risk of stroke may be dose related in the oral contraceptives. So higher estrogen, higher stroke risk. Migraine with aura, non-estrogen containing contraception is favored. And if migraine with aura and there is choice, use the lowest estrogen containing OCP. Follow these patients closely for a change in aura. If you are started on OCP or hormone replacement therapy, then if you have any change in your headache pattern, escalation, or association with aura, get in touch with your doctor. And then we have something called complex auras that are very controversial. Many people will come in and say they have hemiplegic migraine, where they have numbness on one side. That's not truly a hemiplegic migraine, so be very careful with that and make sure that if someone's diagnosed you with that, you get to see a headache specialist, because true hemiplegic migraine, in 30 years of practice, I've really only seen about 3 true cases. So make sure that that's clarified very carefully. So thank you for your attention, and I think we can take questions at this point.